Hello, everyone, and welcome to the Ravitz Way, the podcast where we explore topics in neurology and brain health, from neuroscience to medications to wellness to news to spirituality to exercise and beyond. Let's explore the depths of the human mind and what we are capable of. There are so many podcasts to listen to these days, and everyone has an opinion. Let's try to filter through and separate the facts into undiluted truth. I'm your host, Dr. Risa Ravitz, and I'm not just your average neurologist. My interests and passions run deep, and I'm constantly pushing myself to find truth. I'm a medical doctor, a woman, a surfer, a runner, and an exerciser, and an avid reader of all topics. I feel like it's time for me to share what I have learned. It's not easy to sift through all this information. Let's see who I can meet and what questions we can explore. How can we all be healthier humans? So please, if you enjoy this show, subscribe, rate, and share with your loved ones. Let's go. Welcome, everyone, to Minding Wellness. Glad to be back for episode 2. Here with Dr. Joseph Kranine, my dearest, closest friend, who's also a neurologist. And I'm so excited for him to be here today because he's a sleep specialist. This is something we talk about amongst ourselves constantly. And this is a huge topic in wellness, obviously. So welcome, Dr. Kranine.
Thank you. I'm happy to be here with you. I'm happy to see your lovely office and get to know your staff. And I'm so proud of you.
Thank
It's just really, a dream realized for you.
Thank you.
And I'm glad I'm getting to witness this.
Thank you. So we're going to talk about a bunch of different things, but I thought we'd start a little bit light, and I'm going to share a story about Dr. Kranine and I had the privilege of traveling with Dr. Kranine a lot as we were growing up, and we're both surfers, and we ended up in, actually this was a snowboarding trip. We were in Chile, and I woke up with my sister, with Joe kind of hanging over the bed, staring at my nose. And I was fast asleep, and I woke up, and Joy was right there. Sorry, I say Dr. Kranine. So, what was that about? What were you looking for?
This is not a unique experience. I do this to a lot of people, where I kind of get up in their face, and I'm really directly observing their breathing.
Okay.
As a sleep doctor, the main focus is on sleep breathing problems, specifically sleep apnea. There are different types of sleep apnea. We may talk about that, but I was curious if you and your sister were having abnormal sleep breathing because of your facial structure.
Yeah. You want to get into some details about that?
Yeah. So this is a great opportunity to disabuse some people of when they think about sleep apnea, they think, oh, that's for heavy people, overweight, obese
True.
people.
Very true.
There is a very strong correlation there with being heavy, but thin people can get it too. And this is often overlooked, even among doctors, primary care, some specialists. People will come in with sleep complaints, and they'll look at them, and if they don't fit the profile of being like a big fat person, then they'll often say, oh, I don't think you have sleep apnea. Let me give you some Ambien or something like that, which can add fuel to the fire of sleep apnea. So there's a phenotype that I call like skinny person sleep apnea. When we're talking about this, I'm specifically talking about obstructive sleep apnea. So what that is all about is that the upper airway is too narrow at baseline, and then during sleep, when muscle tone relaxes, the upper airway is repetitively collapsing on itself. And as it starts to get fairly narrow, tissues in the back of the throat, specifically the soft palate and the uvula, as our viewers may not know, is the dangly piece of tissue that hangs off the bottom of the soft palate in the back of the throat. Those tissues start to vibrate, and it creates a snoring effect. So snoring and obstructive sleep apnea go hand in hand. So anyways, the skinny person sleep apnea phenotype is someone who has a narrow face high arched palate. So what I mean by high arched palate is you look in their mouth and the roof of the mouth goes up and up and up and up. It keeps going. And they tend to have smaller mandibles. Now, I was worried about you because you do have a narrower facial profile. You do, I believe, I made you show me, I do believe you have a higher arch palate, but you have a really good mandible, lower jaw structure. I think that's your saving grace. Yeah. So for now, you're good from my direct observation. But the other thing why I did that was I was having a really tough time sleeping. We were at like 8,000 or 9,000 feet.
Yeah, 83.
And I have terrible trouble sleeping at higher altitude. At higher altitude, another type of sleep apnea starts to kick in called central sleep apnea. This is basically where your brain is forgetting to breathe. And when you're at altitude, you can get into a pattern called periodic breathing where you have a regular rhythm of over breathing, then your brain wakes up, and then you fall back to sleep, and then under breathing, and then your brain wakes up, and then over breathing. It's this cyclical pattern of over breathing and under breathing with a lot of brain awakenings. I was having a really tough time falling asleep, and I was having a tough time staying asleep after the first half of the night.
I never knew the physiology of this, but there's, the whole headache, I'm specialized also in headache as well.
Of course, yeah.
And that, at altitude, people get headaches all the time. And I thought it was just the low oxygen, but this is probably the key factor for why it's getting worse.
Your sleep is going to get, for most people,
derailed.
Very disrupted.
So more excitatory brain, so more in the morning.
It's just a lot more
awakenings.
What we would call arousals, cortical arousals. So your sleep is much more fragmented. You have poor quality sleep.
So you're going to get more headaches. It's so interesting.
Yeah.
Okay.
Yeah.
That's something.
So I was also, I think, kind of checking you guys out to see if you were having this fluctuating pattern of breathing too. Because I was having a real tough time sleeping there. And that's happened to me every time I've been at higher altitude. Yeah.
Really good to know, because I think as doctors and people I see, I literally only think about sleep apnea in heavier people, and what we learned in school was very short about sleep, but just the weight kind of here and on the neck. I never learned about the upper airway.
It's true. So with neck circumference for women, a neck circumference of 16 inches or more. For men, a neck circumference of 17 inches or more is a known risk factor for obstructive sleep apnea.
Okay.
But a lot of it is genetic. It has to do with the facial structure that you inherited from your parents, and the facial structure influences this. We're talking about this ear, for your ears, this piece right here. It's all about what's happening back here, and we talked about this kind of one skinny person sleep apnea phenotype. There's another too, which I think is important.
Tell us.
So going back to residency, we did residency in the same city. I was at Kaiser. You were at Harbor, UCLA. Where I worked, we were pretty close to Koreatown, a neighborhood of LA that had a high concentration of Korean Americans. And I would see, being in neurology, doing neurology training, a disproportionately high number of youngish Korean Americans coming in with stroke. And they almost all had high blood pressure. And it was a question in my mind.
Like, give us an age range. It's
30s to 50s.
That's young. Okay. So that's.
And I'm like, why is this happening? And what is it? The diet? Is it high sodium foods like kimchi, things like that? And
kimchi's high sodium?
Oh yeah.
Oh.
Yeah, I believe so. So I always had this question in my mind about this, but only later when I did my sleep training, I found that thin Asian people often get overlooked for having obstructive sleep apnea. And I'm relatively protected from sleep apnea with my facial and jaw structure. Although last night I think I had some snoring. I kind of woke up with a little snortle, but I did have a few drinks, confounding factor.
Do you think they overthink this though, as a sleep doctor?
I've tested myself numerous times for sleep apnea, so it's quite possible. But if you look at my face, it comes way out forward. There's a lot of space. I'm relatively protected from obstructive sleep apnea because my face comes way out forward. I also have a pretty well-developed mandible. But people of Asian heritage, this plane for their maxilla is much shallower. It's flat, and it's going to impinge upon their upper airway and make it more narrow. So, in my experience, Asian people they tend to be more slender. They often get overlooked for being at risk for obstructive sleep apnea. And it's my hypothesis that untreated obstructive sleep apnea is increasing their risk for hypertension, which is then creating other problems like stroke. Yeah. So very commonly, I'll see relatively thin Asian people who have rip-roaring obstructive sleep apnea, like much worse than you would expect. And they're shocked, and I'm not shocked anymore, but they have been often overlooked for years and years because they're not heavy, and people just don't think that they would be at risk for that. Yeah, so
good to
close the loop, I think that people that I was seeing with strokes, these young Asian Americans, I think that the obstructive sleep apnea was probably a factor in why they developed that.
Great information. So segueing into the next part of what I want to talk about. So you and I both know that the risks of having sleep apnea for a long time are really bad. Really bad. Okay? I think people walk into my office every day and we talk about sleep. There's books written about sleep. There's gurus. There's, it's talked about. But what really can happen is what? People that have obstructive sleep apnea or other sleep apnea or sleep issues, what does that lead to? Let's break it down because it is scary and I want people to know about it. I want people to know that if we can fix this, they're going to fix a lot of things that are really bad and dangerous in the long run. So definitely sleep apnea leads to hypertension.
Correct.
We know that. And then hypertension leads to everything else.
Cardiovascular disease. Yeah.
Cardiovascular disease, heart attacks, stroke, waking. Let's talk about the waking part. Why? What's going on there? Is there more details about that?
I like to, when I'm counseling patients, break things down into two big buckets and then like a tiny little bucket. So bucket number one, I describe it as quality of life stuff. So these are symptoms that are going to take away from your quality of life, your ability to feel good and function well. So typical symptoms of untreated sleep apnea: trouble staying asleep, waking up despite getting normal amounts of sleep, not feeling refreshed, morning headaches, increased frequency of headaches if you're prone to headaches throughout the day, excessive daytime sleepiness, more often in men. Women usually complain more about excessive fatigue. And the differentiation here is sleepiness is the tendency to doze off when you don't want to. Fatigue is overall lack of energy. And then a number of neurocognitive issues: impaired attention, memory, focus, mood.
Which is a huge complaint when people go to the doctor. in general and go to see a neurologist.
Yep.
So that's the first thing we like to talk about.
Bucket number 2 are the secondary medical comorbidities of long-term untreated obstructive sleep apnea. So there you've got, like you mentioned, hypertension, type 2 diabetes, heart disease, stroke, depression is put in there, and even potentially dementia. The third little bucket.
Real quick, I'm going to interrupt you because this is always asked by my patients. What is the detailed link between dementia? Let's talk about how many years. Let's give a good range for people of poor sleep. Do we start to see, let's say, brain changes that would qualify someone as having mild cognitive impairment? I know that's a tough question because it's a little vague about, and how we diagnose that is a little bit vague, but let's just give people a little bit of an idea. How many years of poor sleep and obstructive sleep apnea did the studies show that it can lead to increased rates of dementia, mild cognitive?
The answer is I don't know, and I don't think we know as a scientific community. People ask me that all the time when I'm going over results, and they have really bad obstructive sleep apnea with really bad oxygen desaturations or really bad average oxygen level. They say, well, doctor, have I already done some damage? And my answer is, I don't know. You seem to be functioning well now. Could there have been some damage? Maybe, but let's try to right the ship. So I think the way I like to think of it is we all have like a neurological reserve, right? Where I think the most likely mechanism with obstructive sleep apnea is the intermittent hypoxemia. So you can have absolutely profound oxygen desaturations from these obstructive breathing events. I've seen down into the 50s.
Wow.
So logically...
So normally for our audience too, what's the normal resting level oxygen? So people
resting level oxygen, while we're sitting here in New York City at sea level, should be 95% or higher is normal.
So 50%. So that's bad.
Down to the 50s. So I think the most logical link is you're having these oxygen drops. I think the two most metabolically active tissues in the body are the brain and the heart. They like a lot of oxygen and they need it consistently with no interruption or bad things happen. And I think when you have these oxygen drops, probably cells die. We have so many neurons that you can have this going on for years and not notice anything, but at some point there will be a tipping point where you've had enough cell death where it starts to affect your ADLs, your activities of daily living, or your ability to do a crossword puzzle or whatever it is that's got a higher cognitive demand task. You're going to start to notice impairment from it.
Absolutely.
That should be differentiated from a sort of pseudo dementia that you might see from just terrible sleep.
So
that could be corrected, right? You're just not sleeping well. You're going to feel foggy, hazy. People say brain fog a lot, and you should, with treating the sleep disorder, you should have improvement in that.
So one thing I wanted to bring up that I have a question about, and I try to tell my patients, what is the science behind deeper sleep and neurons pruning and cleaning and repairing? So there's that concept of glial cell, the support tissue in the brain getting cleaned up at night. Do we get into that, or because I think that is actually really relevant as well? So
the theory is now that bad stuff builds up in the brain during the course of the day.
So inflammatory substances and oxidative free radicals and so forth. Things that are not good.
I forget exactly what. And during sleep, the brain cleanses itself through this like glial lymphatic fluid, if I recall correctly. It kind of
Not well understood.
gets rid of these bad humors that have accumulated in the brain, which are toxic, and helps restore and rejuvenate. So specifically, you're talking about deep sleep. So deep sleep is now called N3 sleep. So it used to be stage 3 and 4. It's characterized on the EEG, the brainwave electrodes, as these big waves, brainwaves that look like kind of mountains, and the brain is very, very relaxed during this period of time. And in deep sleep, it's true, that's when we do our repair, catabolic, we're restoring muscle and stuff like that. That's where we have our biggest pulse of growth hormone, is during the deep sleep, and that growth hormone helps our body rebuild, repair. But also,
So super important.
super important.
Super important.
Yep. Also important stuff happens in REM sleep, but it's like the opposite. It's pruning. We believe that in REM sleep, the brain is pruning and getting rid of connections in the brain, synaptic connections, getting rid of
It's not
memories
overloaded.
and things that we don't need anymore.
Cleaning up a garden.
Yeah. So equally important, but opposite sort of process.
So interesting. It's amazing. So let's give some, you're as the sleep expert, the big tips that the must-haves, the must-dos, okay? The things that we have to make a priority for our sleep. Because they're the obvious ones, but let's hear it from you, because you're the expert. So how many hours, what's the environment, anything else you can offer?
Number one with a bullet is get enough sleep. So this is probably overall the biggest sleep
And what
problem.
people try to get around, right?
Yes, people typically think that they can get away with
5 hours.
5-6 hours of sleep, and they think, I don't need it. But they actually do. Most people, there are a lucky few who are what we call short sleepers, who legitimately only need less than 6 hours of sleep per day. It's a very, very small percentage of the population. Most people who are getting that amount are just sleep deprived, grossly, chronically sleep deprived. Yeah.
Okay. So is there a recommended range of number, or what would you say?
The standard is most people need between 7 and 9 hours of sleep, but really, I think the vast majority need between 7 and 8 hours of sleep per day.
And what do you think the population of New York is getting?
It's really tough to sleep here. I feel for you guys.
Yeah.
It's really tough. I have consistently had bad nights of sleep in
New York.
Yeah. Yeah. It's really tough because it's really expensive. People live in small spaces in buildings. Most of these buildings are old. You can hear your neighbors. You can hear, it's loud. It's the city that never sleeps, right? There's cars and buses and sirens and all this stuff going 24/7. And you can hear this. Your brain, even if you think you're asleep, it can be causing your brain to have like micro awakenings, this kind of noise and light pollution that's coming in from the city.
So reduce noise as much as you can. Reduce light. Okay.
Also, we've talked about temperature.
Yeah.
A lot of people who live in these
Whole
older
other topic,
buildings
but
have
yes.
very little control about the temperature, and temperature is important too. Ideally, you want it quite cool when you're sleeping, like mid to upper 60s is
That's
what the
cool.
research would suggest. Yeah,
That's cool.
yeah, it is cool.
Mid to upper 60s
Yeah.
is what it
Yeah.
suggests?
Yeah.
The whole line.
Yeah,
And the science to just get better, deeper sleep.
Tends to promote that, yeah.
Huh.
Yeah.
Wow.
It's better to have the room cold with like a bunch of blankets. When you think about it, evolutionarily, that's for the duration of human experience, that's probably what was happening. The cave was cold, had no source of heat, and you had a bunch of animal skins or whatever on top of you to keep you warm. So we've probably evolved to want our bodies
better, actually. Okay. So, all right, another New York thing, or everywhere thing. So caffeine, which is its own podcast in itself, no, its own episode in itself. But let's give some good guidelines for last time you can have caffeine. That's the safest to make your sleep the best. Because I usually tell people by noon, but I'm a headache doctor, so I am trying to think of other things as well. What would you say?
I hate to do this to you, but it's going to be one of those lawyerly answers. It depends. So I've had people come up to me and say, "You're a sleep doctor? I can have a double espresso and then go right to sleep. What do you make of that? Why does that happen?"
Me too.
And I'm like, well, good for you.
You're lucky.
Probably they've become so habituated to this amount of caffeine that their body is not reacting to it anymore, and or they could be a fast metabolizer of caffeine. Or they're only sleeping for 4 hours, and it doesn't really matter how much caffeine they're going to have. They're going to fall asleep when their head hits the pillow. But it really depends on how the person's sleeping. I think if you're not having trouble sleeping, then don't worry about it. Just try to keep it.
I like that.
6-8 hours away from bedtime would be a good rule of thumb. If you're having insomnia and it's chronic and it's problematic, then you really got to get into that. The best answer would be have zero caffeine, really, because there is some research that shows that caffeine lingers a lot more than we thought. We think its half-life is
2 to 4 hours.
Yeah, relatively short, but it can kind of build up and kind of, as the caffeine curve of metabolism starts to come down, it can cause problems.
For sure, and like everything else, even with headache medicine, the overused headache, the receptors of the cells in any drug you take, as you take more of it, you build more receptors, and then it accepts more, and it's a different. You're at a different threshold and baseline for everything. So I believe that, and that's definitely there is probably some habituation to that. Okay, what else do we want to know about actual practice? Okay, let's talk about the real controversial things. All right, I know the real ones. All right. I'm going to give you two choices, and let's just go. Okay, so it's going to be melatonin, bad or good?
For the vast majority of people, indifferent.
Interesting.
Yeah. So melatonin, we know that it helps you fall asleep, but it's a very small benefit. Like, people in rigorous studies fell asleep, I think something like 7 minutes faster than those who didn't take it.
Too? People are taking it, and then
it can be extraordinarily effective for certain circadian rhythm sleep disorders, which is where basically your circadian rhythm sleep disorders are where your internal clock is out of whack with the real clock.
So you fly somewhere. You fly somewhere and land somewhere.
Is one.
An hour.
So it is possible with careful planning to use very, very small, like microdoses of melatonin, with or without exposure to bright light, to pre-shift your internal clock. So when you land in Paris, you don't have jet lag or significant jet lag. You're kind of on the pre-time schedule.
Okay.
So, but also certain people have jet lag without going anywhere. These are people that have what's called advanced sleep phase circadian rhythm sleep disorder, or delayed sleep phase circadian rhythm sleep disorder. So advanced sleep phase means they want to go to bed very early, and it puts them out of touch with society. And then delayed sleep phases, they want to have the tendency to want to go to bed very, very late, and it also causes problems. In those cases too, melatonin can help to move their sleep cycles around.
Okay. Over-the-counter sleep aids, Tylenol PM. So most of these over-the-counters have diphenhydramine.
Right.
Good or
Benadryl,
bad? Benadryl, diphenhydramine. Good or bad?
Net bad, I would say.
Okay.
Net bad. Diphenhydramine, it's going to make you fall asleep. It's going to give you psychologically a feeling like you got more sleep, but it tends to keep you in lighter stages of sleep. To generalize a bit, you don't get as much deep sleep.
Okay.
Typically when you take diphenhydramine. It can also exacerbate in those prone to restless leg syndrome or a cousin of restless leg syndrome called periodic limb movement disorder. It can really exacerbate that, and then that can chew up your sleep quality.
Okay. Okay. Hypnotics, Ambien, Lunesta, all these fancy prescribed controlled medications. Good for sleep, bad for sleep. And I know that's a little bit of a trick question, but let's say long term.
Long term,
3 months from now.
There's pretty decent and compelling evidence that long-term use of these sort of hypnotic medications like Ambien is associated with an increased risk of dementia. Now, it's an association. So it could be that people who are prone to dementia just have worse sleep.
Mm-hmm.
And so they're asking for these medications more. Or it could be a causal relationship where taking the medications long term promotes dementia. We just don't know. But it seems prudent, especially given that ostensibly medications like Ambien don't cause tolerance or addiction, but yet they are Schedule 4 drugs. So there is some
drug, and you and I both know. There's so to get to be a Schedule 4 where you need a special license, there has to be reportable evidence of addiction, during a study, which is a broad term, but it means that people feel like either they had symptoms of withdrawal or they have to have it. So whether that's true physiologic dependence or a very big mind dependence, it's pretty real in my mind as a doctor as well, because a person is having an association of even just having to take this, and I think it's something to think about, like as a doctor when we prescribe this and we do it. So I want patients to know this. If they need it, they need it. I'm not arguing that, but I do think I want people to know about that. And I love that you brought up the dementia thing, because we are seeing more and more that these medicines that we are using for many, many years have a strong association with dementia and cognitive impairment. So we'll segue into...
I might add, that's why I love CPAP. So a lot of these folks were coming in asking for Ambien, Lunesta, what have you. They actually have sleep apnea, and that is the cause or a major contributor to their symptoms. So a lot of times, if you can convince them to do a sleep study and you find sleep apnea, and you convince them to use CPAP, which is basically it's like a natural treatment, air to hold your throat open. Mm-hmm. Isn't that a wonderful solution compared to taking a drug that could be problematic? You're just using air.
Yeah.
And that may fix the root of the problem.
We're not going to talk as well, but people can get surgery to actually remove tissue if there's too much tissue. I would
not recommend that.
No?
That is... No.
All right.
No go.
What if they have huge...
That is a whole... Okay, so that's something that should be only really thought of in the context of pediatric patients, so people less than 18. If children have obstructive sleep apnea, there are two first-line treatments. Getting the tonsils and adenoids out, called an adenotonsillectomy, or CPAP. Most parents elect to go with the adenotonsillectomy because trying to wrangle a kid to use a CPAP is not the easiest thing. When you're above 18, it's not indicated. That said, I've become personally more open-minded to it. I had a rip-roaring case of strep pharyngitis this past summer, and one of my tonsils got huge. And my wife said I started snoring very loudly.
Yeah.
And I was like, it's gotta be that. It happened very acutely. And I felt so bad because I thought back about all the people that came to my clinic who were like, doctor, 2 weeks ago, I developed sleep apnea. And I'm like, I always think that, no way. It was a steady march up to more and more narrowing of the airway. Now it's tipped over, they're noticing it. But now I'm like, I might have missed opportunities to intervene and help. But this is why it's the practice of medicine. You just keep learning as you're going.
And I have to tell you, the people we always talk about New York, we always joke about New York and stress level, right? Where does stress go? It goes to many different places. I have a lot of patients, I should say, with just enlarged tonsils. Like they come to me from ENTs, they have enlarged tonsils. For years they don't know why. And they're big. They're not like a little bit.
I would say if you have obstructive sleep apnea and you're youngish, maybe mid-20s on down, it's reasonable to go talk to an ENT, but what usually happens is they get it out and there's a little bit of improvement for a lot of pain and suffering and not total resolution of the problem. That's the typical scenario with adults who get tonsillectomies. I think it's an important point to add. A lot of adults say, I think I have big adenoids. I want to get my adenoids out. It's going to fix my problem. That's the cause of my problem. I know it's my adenoids. Well, what people need to understand is your adenoids, as you become an adult, shrink to nothing.
Yeah.
It's not the problem. It's never the problem in adults.
I got you.
Yeah.
Okay.
But I think it's also very important to bring up that there are some upper airway surgeries. I think you might have been including these in cutting tissues out that generally should be avoided. So the popular one was something called the U-triple P. Get ready for this. Uvulopalato-pharyngoplasty. This is where an ENT goes in, cuts out the uvula, cuts out most of the soft palate, all the tonsils, and then takes the muscles in the pharynx and tries to make it tighter. Unfortunately, it doesn't work well. It's maybe long term.
That's not what I was talking about in terms of that. I was not recommending that.
But that said, there is a surgery that in the right patient can be up to 90% effective. It's called, colloquially, the BiMAX. So this is maxillomandibular advancement. This is actually done by an oral maxillofacial surgeon, not an ENT. It's pretty brutal. Ready for this? They break the upper and lower jaws and move the whole thing out like a centimeter.
I heard about
and your jaws are going to be wired shut for 4 to 6 weeks. Eating through a straw. But especially in thinner people who have retrognathia, which means your mandible set back, or micrognathia, which is your mandible's really small, can be very effective.
So I've had patients that have had this for cosmetic reasons, and I think it's improved their sleep apnea.
Yeah, it's going to change the way you look.
Yeah, for sure.
You're going to look different, and you can have some permanent numbness on your cheeks from nicking the branches with facial nerve here. So those are considerations. It's a big decision. A lot of people hear about that. They're like, I think I'll try that CPAP.
Yeah. Oh, good information. All right, another big one that I know has ramifications down the line that we've been talking about, benzos. So these are Valium, Ativan, Xanax, what am I missing? Klonopin, okay? Good or bad? And the question is going to be definitely longer term. So answer how you like.
Good or bad for sleep?
Yeah.
They're going to help you fall asleep very quickly. They're going to probably keep you asleep, but they're going to also prevent you from getting in and staying in deeper sleep. It may reduce your REM sleep too. So it has a net negative effect on your sleep architecture, as we call it.
Okay.
Long term, terrible.
Terrible.
Probably the most dangerous, I would argue more dangerous than opiates.
I agree with you.
The withdrawal syndrome of opiates is very uncomfortable.
Not dangerous.
But not going to
not
kill you.
Not life-threatening.
Whereas withdrawal from benzos, seizures, death, very, very dangerous, has to be done under supervision, usually with sliding scale of reduced dosage of benzos to help you get through. When we're looking at a level of badness, of course, as you know, Xanax is the worst because it's super short acting, and the faster the onset and offset, the more habit promoting it is. People are like, give me another one, give me another one, give me another one. Where the Klonopin and Valium, much longer acting, less dangerous. If you were to stop, it's so long acting that your risk of a major withdrawal reaction is less. Not absent, but safer.
I think in my experience as a doctor, what happens is, first of all, the tolerance for benzos builds very quickly, meaning you get a dose of 5 milligrams of something and that works for 3 months, and then all of a sudden that 5 milligrams doesn't work as well as it used to, so you go to 10, it quickly escalates. And that's a problem because you're at higher doses, and then it's risky to come off of it, and then you're reducing your sleep. But what I think is so interesting is the data that keeps coming out about cognitive impairment and dementia 10 years out from chronic use. So people using benzodiazepines for greater than 10 years, the data is pretty compelling. And I don't know if you've seen some of this data, but it's pretty compelling for cognitive impairment. And that's telling me, just my theory, is that the pruning, everything that's happening at night for good natural sleep, what the body needs to do over 10 years is affecting memory. And it's a big statement. I know that's a big statement. It's pulling, causality of two big things, but it's very interesting data, and it's frightening. And it's something I tell my patients. I do not want them on this long term.
The other one we should talk about when we're talking about sleep is temazepam, which is the benzo that's classically been used for sleep. I myself, having practiced for 15 years, have never prescribed it.
Same.
It's often prescribed by psychiatrists, like older school psychiatrists. You don't see it that much anymore, but it's a relatively long-acting benzo.
Yeah, I see that a lot still, and I can tell you, listen, you have patients that come in and they're desperate. It's like they're desperate, they don't sleep, and you try to give them, I don't fault, people for trying to help somebody else, but we have to start thinking, longer term and helping people not to do something that they're potentially going to get addicted to and also ruin their sleep,
Here's the problem. Like, you're seeing someone, they're on temazepam. You want to have a nice interaction, make them happy, satisfy them, help them, all of these good things. They want that refill from temazepam.
Yes.
You may know that they need a sleep study. Who wants to do that? It's a lot sexier to take a little pill than to wear some mask on your face.
It's an easy, quick
fix. And sexier.
Mm-hmm.
No one wants to do that.
And a lot of people, sexier than the mask?
A lot of people think, even married people who've been married for 20, 30 years, they're like, I don't want my spouse to see me like this with a mask on my face. Like, do you want them to see you dead in your bed?
Out?
Yeah.
Stroked out. Yeah. Speaking of minding wellness, this is one of the biggest topics, questions, things that are going on in 2023 in the medical world, in the civilized world, everywhere. In New York City, what about weed? Okay, what about weed? What about THC? Let's talk about quick fixes. So THC, weed, let's start with just the THC component, good or bad for sleep?
Well, interestingly enough, the holy grail for sleep apnea has been the pursuit of a pill that would be an effective treatment. And there is at least one in the pipeline that is based on THC or some
receptors, or the like
some. It's like a cannabinoid based
okay, so that's different than THC
molecule.
Okay.
I'm not sure if it's THC or CBD or whatever, but it's derived from marijuana, and it's the preliminary trials show that it has pretty good data. I don't think it's looking like the Holy Grail, but like a help. I think that's what the expectations are. So, in general, there's just so much anecdotal evidence that it helps people's anxiety and their sleep. I think there's likely something to that. Does it have any negatives for sleep? I don't know. Here's my take.
I've heard some. I'm going to interrupt you real quick. I've heard some research that there is net negative about the restorative components of sleep, but we can look at that. We can definitely look at that.
Okay, maybe we can follow up in the notes.
Yeah.
Here's my opinion. I think that there were these draconian regulations for marijuana for so long that were probably over the top. And in order to get weed, which was already ubiquitous, more considered to be on the level of like alcohol, I think weed activists had to make these claims that was basically safe.
Yeah.
It was natural, there's nothing wrong with it. And it's been very effective in changing, obviously, the legislation and the laws in our country.
Yeah.
But I think there's now a misunderstanding about marijuana that it is safe. And we know that there are downsides to it. So I think that this pendulum has swung from one side, reefer madness, to the other. It's just a natural supplement, if you will. And I think neither one was right. The truth is somewhere in the middle. But now it's kind of hard to do studies. The work saying that it's not so good, because it kind of threatens the, now established law and mentality in society that it's okay.
Alcohol for sleep, good or bad?
Bad. Yeah.
Tell me what.
That said, it's great at putting you to sleep.
Okay.
But it destroys the second half of your sleep. So what we know is that people often use alcohol for sleep. It puts you right to sleep. But the way I like to tell the story is that alcohol, we got to remember, it's a CNS depressant. So it's like pushing down on your brain, like be calm, be sleepy. As you metabolize that alcohol, your brain starts to push back. And in the second half of the night, after you've metabolized it, your sleep is going to be, after a night of excessive alcohol intake, the second half is going to be very fragmented. Your brain is waking up a lot. The way I like to think of it is that it's like pushing, it's like doesn't like to be suppressed, and it's pushing, and then it gets an edge, and it's like keeps pushing.
And then it's more excitatory.
Yes.
And then it's over-excitatory.
For the second half of the night, you're going to have a lot of awakenings and fragmented, you're going to have loose REM, and then the next night you're probably going to have a REM rebound if you don't drink, or you're going to have these vivid dreams, and you can kind of wake up from that too.
And longer term, this is,
Well, we know from chronic alcoholics, unfortunately, there was a very famous study that when they stopped drinking, the biggest complaint, the biggest risk factor for going back to alcohol was insomnia. And unfortunately, for as long as the study went, after they had ceased alcohol, they still had poor sleep quality. They still had insomnia. Now, the study ended, I don't know, a year or something later. Maybe it eventually did get better.
No, but it changes the baseline. I always tell my patients, you have to worry about your baseline, because that's really important.
It's also going to increase your risk for sleep apnea, or exacerbate a sleep apnea with the muscle relaxant effects of alcohol. It's going to make your throat more floppy. And it's going, as we said, it's going to keep your brain pushed down into sleep. So it's harder for your brain to wake up from the throat closure event and tell your muscles to open up. So there's more like suffering and damage that can happen.
Okay. All right, we're going to have to wrap up soon, but I want to ask you about Inspire.
You're going to hear a lot about Inspire if you haven't already.
Okay.
Inspire is advertising like heck.
Okay.
They're all over,
What is it?
all over cable, all over TV. It's basically like a pacemaker for your tongue. It's an invasive solution for obstructive sleep apnea. There's like a pacemaker sort of device that's implanted in your upper chest, and an ENT, ear, nose, and throat surgeon does this, and then kind of buries, and it's in simple terms, a wire to your tongue. And when you're ready to go to sleep, you have this remote control, and you turn it on, and it electrically stimulates your tongue to stay firm. So that prevents the tongue from moving backwards and occluding your airway. This is very sexy to people compared with having to use a CPAP machine. I've had, in the last few months, numerous people out because they're seeing the ads and they think, this looks great. But they don't realize part of the inclusion criteria, meaning before they'll even consider you for this, you have to have tried CPAP, right? And they don't necessarily realize what it involves, that it is an invasive procedure. And when I describe it to them, most people are like, no thanks, I'll try that CPAP. I'll give it the old college try.
Okay.
And what I'm hearing from my colleagues who deal more with it, I have like a WhatsApp group with like dozens of sleep docs from University of Michigan where I did my training, is people are generally saying their experience is that it helps like maybe like 50% better.
Okay.
Because what you got to realize is there's multiple levels of potential airway obstruction. One is right behind the soft palate, like kind of behind the nose. Then there's retrolingually behind the tongue. That's what Inspire works on. Then there's one a little bit lower than that. So it's only really going to work on that one level. You wouldn't expect it to be 100% effective in 100% of people.
Gotcha.
But since they got approval from Medicare and insurances, they can bill. They have been going all out with advertising.
So, overall, it's great information. I feel
maybe we can do a part two. I feel like there's
there's so much to talk about, and I want to say I'm thrilled that you came on here. I'm so happy you came to visit New York City. I'm
happy that you flew me down on a private jet and picked me up with that limo. That was a really cool stretch limo. It was awesome.
Yeah. Hot tub?
Yeah.
Hot tub in there?
There was champagne. I mean, talk about alcohol.
Amazing.
Yeah.
So, no, I am thrilled. And a lot of times people want to know where to find you. And I just want to say that I am also very proud of you because we both went through a lot of training and really care about what we do. And you were trying to do another kind of model to get people, give access to people to get tested and studied, and you were doing telemedicine before it was cool and before it was on the map, and you actually sold your company, so mazel tov and congratulations, it's amazing, and I'm super excited to see what's next for Dr. Joey Kranine, and we're going to have to do a part two because there's so many things we didn't talk about. We didn't even talk about like medicine, the business of medicine, which talk about that. I think we need to get into some of these topics about marijuana and some of we can talk about mushrooms. We can talk about a lot of things. So
I think you and I are, and my sister calls you the female Joey and you the male Risa. I think our mentality on so much stuff is like, but for this conversation, I think it's important to point out that I think both of us, although as neurologists, we're kind of trained to be pill pushers. That's the tools that we have generally.
Yeah.
That we really want to get to the root and find the truth and do the least invasive thing to help
and
people. I think
big
you and I
picture and long term, and also So sleep affects headache. I didn't even make that association, but headaches, memory, everything. Really wellness, aging. How do you age like a good human? And sleep is, way up there in terms of importance.